In this video, we'll go over some of the other childhood onset psychiatric disorders. Here are some of the childhood onset communication disorders. The first is speech sound disorder, when someone has a lisp or is lisping and misarticulates sounds. Here are some of the most commonly misarticulated sounds, such as the L, R, S, or Z sounds. The next communication disorder is child onset fluency disorder. This is when someone has a stutter and has a hard time moving past a particular sound. Stress and anxiety can exacerbate this disfluency. The treatment for both of these tend to be speech and language therapy, improving breathing techniques to reduce anxiety during speech, and typically muscle strengthening to help improve the way that words sound. The next communication disorder is social pragmatic communication disorder. This is when someone has deficits in following social rules of verbal communication. So someone might have overly formal speech when talking to their friends, or they might speak to their teachers as one would speak to a baby. This is a type of communication that you could see in an autism spectrum disorder. However, when someone has a social communication disorder, they do not have the other features of autism, such as having restricted or repetitive behaviors or interests. And I don't know if you picked up on this, but if you were listening very carefully, you would have noted that I had a little bit of trouble getting past the R sound in repetitive. So that was a little bit of stuttering or disfluency, similar to what you might see in a child onset fluency disorder. Next, let's discuss selective mutism. So selective mutism is when there's a failure to speak in social situations when expected. And although this is a communication issue, it is not a communication disorder, but it is an anxiety disorder. Now, this has to occur for greater than 1 month for the diagnosis. It has to interfere with functioning, and it can't be attributed to lack of comfort with a particular language. So it can't be due to someone coming to the United States and having trouble with English as their second language. It is a very rare disorder, and it usually develops before the age of 5. A risk factor for someone developing selective mutism is having overprotective parents or parents with their own anxiety issues. On the differential are the communication disorders, some neurodevelopmental disorders, and then social anxiety. Commonly, this can be comorbid with social anxiety disorder or separation anxiety. And the treatment for selective mutism is really behavioral therapy and then exposure therapy to gradually expose a child to different speaking tasks. Let's move on to separation anxiety disorder. This is when someone has terror and panic when anticipating or experiencing separation from home or major attachment figures, typically the parents. These children have a lot of worry about losing their caregivers. They worry about events that will cause separation, and then they refuse to go out or go to school. They have an intense fear of being alone, and often they have nightmares with the theme of separation from their parents. These children oftentimes have a lot of somatization symptoms or physical symptoms like headaches, vomiting, stomach aches, as well. To give a child this diagnosis, the symptoms must persist for greater than 1 month. We see an equal prevalence of this disorder in girls and boys. Increased risk occurs with the same things as what we saw with selective mutism, with parental overprotection or parents with their own anxiety issues. Now, separation anxiety disorder can newly develop after a new life stressor, such as a loss of a pet or relative, being in a family that's going through divorce, or having gone through a disaster type situation. We commonly see comorbid with separation anxiety disorder, generalized anxiety disorder, social anxiety disorder, and then other sleep issues. And here's a picture of a child sleeping between their parents in bed, and you commonly see this in separation anxiety disorder where the child will spend every night in the same bed as their parents. The treatment includes therapy, medications for anxiety, and a comprehensive plan with the school if there is school refusal or trouble keeping the child in school due to the separation anxiety. And the course is that most children really improve over time as they just get accustomed and exposed to school day after day after day. There is a poor prognosis, however, if school refusal does not remit. And let's say the parents allow the child to stay home from school or then switch to a homeschooling model of education, then the child may actually continue to experience separation anxiety even into adulthood. 50% of these children will develop other anxiety disorders even if the separation anxiety goes away. And again, so this very rarely persists into adulthood, but it can, if not really treated during childhood. Next, let's discuss the attachment disorders in children. There really are two that we'll discuss, and those are reactive attachment disorder and disinhibited social engagement disorder. Both of these share a common etiology, which is also a diagnostic requirement. Children with both of these disorders have had a pattern of extremes of insufficient care. So they've received care where their basic emotional needs were not met. They might have experienced social neglect and deprivation. They might have had repeated changes of their primary caregivers that limited opportunities to form stable relationships, and then they may have been reared in unusual settings that limited their opportunities to form attachment. So they might have been in an orphanage or other institutions with large numbers of children, but not very many caregivers. So in reactive attachment disorder, the child is inhibited, emotionally withdrawn towards adult caregivers. They rarely seek comfort when they're distressed, and when they do get comfort, they rarely respond to that comfort when they're distressed. They have social and emotional disturbances, such as being minimally responsive in a social or emotional manner. They have limited positive affect, so you do not see laughing, smiling in these children. And they have unexplained irritability, sadness, and fearfulness, even during non-threatening interactions with caregivers. In disinhibited social engagement disorder, you kind of see the opposite reaction. This is when a child is socially disinhibited. They might actively approach or interact with strangers without any hesitation. They might have an overly familiar behavior with strangers, so they might hug people that they've just met and become just really intensely attached to people that they don't really know. They have no trouble venturing away from their adult caretakers, and they're willing to go off with strangers without any hesitation. The treatment for both of these are really to first consider the child's safety and their environment and their physical health needs, and also introduce psychotherapy. Oftentimes these behaviors do become more normalized over time with ongoing therapy and just a change in environment that is unlike what they grew up in. Next, let's discuss encopresis and enuresis. Encopresis is the repeated passage of feces into inappropriate places, and this can be involuntary or it can be voluntary and intentional. For the diagnosis, this has to be occurring at least once a month for 3 months, and the age of the child should be 4 or more years. And it can't be attributed to physiologic effects of a substance, such as the child taking laxatives or another medical condition other than constipation. To treat this, you should address constipation if that is an issue, introduce behavioral interventions, and then decreased anxiety related to bowel movements. You want to make sure with the parents you establish a non-punitive environment. Oftentimes, parents get really frustrated with their children about this, and this can really just make things worse for the child. Children with things like encopresis or enuresis are also higher at risk for being the victims of child abuse. Usually this is self-limited and doesn't go beyond adolescence. Now moving on to enuresis, this is the repeated voiding of urine into bed or clothing, and again this can be involuntary or it can be intentional. And for the diagnosis, it has to occur at least twice a week for 3 months, or just causing significant distress or impairment. The child has to be at least 5 or older for this diagnosis. And just like with encopresis, it cannot be attributed to a substance or another medical condition that the child has, like a urinary tract infection. The treatment is really behavioral, oftentimes just setting reminders for the child to urinate throughout the day, and maybe decreasing the amount of fluids that the child has before bedtime. And then sometimes medications can be useful as well. And this also is usually self-limited, just like with encopresis. Next, let's move on to Tourette's disorder. Tourette's is when someone has both multiple motor tics and at least one vocal tic. And here is a chart with some of the more simple motor and vocal tics that occur, and then some of the more complex motor and vocal tics that occur. The most common simple tics that occur are eye blinking when we're looking at motor tics, and then things like throat clearing when we're looking at vocal tics. But these tics can include things like shoulder shrugging, nose twitching, sticking out your tongue, hiccuping, barking, belching, etc. Some of the more complex tics are tics that require multiple muscle movements. So things like jumping, arm flapping, leg kicking. And when we look at vocal complex tics, we sometimes see coprolalia, which is involuntary swearing, and then echolalia, like repeating others. Now, the onset of these tics in Tourette's disorder have to occur before the age of 18, and these tics can wax and wane in frequency, but for the diagnosis, it has to have been going on for at least a year since the onset of symptoms. If both of these requirements are not fulfilled, and let's say someone just has motor tics or just has vocal tics, then the diagnosis is a persistent motor or vocal tic disorder and not Tourette's disorder. Sometimes people with Tourette's will describe these tics as like having an itch that they feel like that they need to scratch, but they're just trying to resist scratching, or having a sneeze that they're trying to hold in. And interestingly, there are some immunoneurological advances in learning more about Tourette's. So it might have something to do with the immune system. The tics in Tourette's typically begin in the prepubertal period, and the average age of onset is around 4 to 6 years. The initial tics are usually in the face and the neck, and most people will experiencing a decrease in their tics during adolescence. These tics can be worsened by excitement, anxiety, and exhaustion, and they are better controlled during calm and focused activities. So again, it's really important to let parents and family know not to discipline children or not to get annoyed by children's tics, because it will just make things worse. On the differential are other motor stereotypies of neurological disorders like rocking, repetitive movements that we might see in autism spectrum disorder. Substance-induced tics can occur, and then repetitive behaviors are also seen in OCD, so that is also on the differential. The treatment is psychoeducation, behavioral techniques to reduce excitement, anxiety, exhaustion, and then pharmacotherapy such as antidopaminergic drugs can be useful to help decrease tics when they are greatly impairing and functioning. Lastly, we'll briefly cover intellectual disability, which was previously known as mental retardation. Now, there are 3 requirements for this diagnosis. The onset has to be during the developmental period, so this cannot be new cognitive impairment after a head trauma or something like that. There is a decrease in intellectual functioning, so trouble with things like reasoning, problem solving, planning, judgment, and academic learning. And then there is a decrease in adaptive functioning. So this is really looking at activities of daily living. There used to be a reliance on IQ testing to determine the severity of mental retardation or intellectual disability, but this is no longer the case because it is adaptive functioning that really determines the best level of support or treatment or management that is required, and not really the IQ score. You don't need to memorize all of the different severity levels that exist for intellectual disability, but it is important to note that there is a wide range of functioning. So those with profound intellectual disability may be dependent on others for really all aspects of their daily living. Those with mild intellectual disability usually do not become identified until first or second grade. And then those with mild and moderate intellectual disability are more likely to have low self-esteem and negative self-image because they do recognize that they're different from those around them. All people with intellectual disability can be targets for things like sexual assault, and adults with intellectual disability might be more likely to be targets of financial abuse from relatives or caretakers. So these two things are important to screen for in this patient population. The prevalence of intellectual disability is about 1%, and you will usually see delayed motor, language, and social milestones within the first 2 years of a child's life in intellectual disability. The most common cause of intellectual disability is Down syndrome, but the most common inherited cause is Fragile X syndrome. Now, intellectual disability can be acquired during the prenatal period with exposure to things like rubella, syphilis, toxoplasmosis, AIDS, herpes simplex, fetal alcohol syndrome, or other drug exposure. It can also be acquired perinatally or during early childhood. So if there are complications during pregnancy, if there is meningitis or encephalitis during infancy, or head trauma if in infancy, or if there is exposure to lead or mercury exposure. And then the prognosis really depends on the particular syndrome. Some of these syndromes are associated with other medical issues separate from the intellectual disability. So life expectancy, prognosis really depend on the particular syndrome.